Good evening. I'm Margaret Crone, the director of the Physician Health Program, part of the Center for Healthy Maryland, which is part of MedChi. So happy to see all of you for our second lecture for the 2026 edition of Lemons to Lemonade. Just a note, we have 6 informative, thought-provoking lectures planned this year. And tonight, we are so happy to welcome Dr. Michael Heitt, presenting Focusing on Clear Ethics. Before we get started, just a couple housekeeping issues. A note about questions and comments. If you could, please put those in the chat, and we'll hold them until the end of the presentation tonight. Just like other presentations, at the end, though, we'll unmute. People want to ask their question personally, that's fine too. CMEs. Everybody attending this evening will be sent a link to the CME questionnaire in the next couple of days. Please complete the questionnaire and submit it, and you'll receive your CME certificate within 7 business days. Please be generous tonight with your enthusiasm for our speaker, but also with your support of our lecture series and the work that MPHP does. Last year, we helped over 100 participants with problems ranging from substance use to mental health, to stress and burnout, to licensing sanctions. So please donate, give generously so that we can ensure that all who need compassionate, confidential help are able to receive it. All right, now let me introduce Dr. Heitt. Dr. Michael Heitt is a licensed psychologist in private practice in Baltimore, where he focuses on the clinical and consultative needs of physicians and other healthcare professionals, senior executives, and other high-stakes professionals navigating personal and occupational challenges. Beyond his clinical practice, he's sought-after organizational consultant and is recognized by the local courts as an expert witness in both clinical and forensic psychology. A leading authority on professional ethics, Dr. Heitt is former chair of the Maryland Psychological Association, the MPA's Ethics Committee, and their Colleague Assistance Program. He continues to serve as a member of the MPA Ethics Committee and shares his expertise as the lead instructor for the Maryland State Jurisprudence Licensure Exam preparatory course offered by MPA. He provides ethical consultations for mental health practices and independent practitioners. Dr. Height's presented internationally on a wide range of critical issues from workplace violence and professional impairment to disaster psychiatry and psychological ethics. His academic background has included faculty appointments at Johns Hopkins University and Loyola University, Maryland, and he earned his doctorate of psychology from the Illinois School of Professional Psychology. So we are so honored and fortunate to have Dr. Heitt with us this evening. It's on you now.
Thank you, Margaret. I appreciate that. And so I'm really happy to get started. I'm glad that everyone braved the weather, made it to wherever they are, and they have power. So that's a good start. So let's jump in because we've got a lot of really great information to go over today. I know a lot of times when people talk about ethics or they take an ethics course or an ethics class, it's either boring or scary. And I don't want this to be either. And so I kind of approach it a little bit differently. So our plan, I'm going to start off with just a little bit of introduction and contextualization. We're going to go over just a couple examples of state laws and regulations. We'll talk about the APA Code of Ethics relatively briefly. And then we're going to jump into my model of ethical reasoning, the clear plus lenses. So let's move forward with that. And of course, I'm giving an ethics talk, so there's a little disclaimer there. Another kind of disclaimer is, Margaret, kind of gave the introduction for me, but I like to, remind people that this is just one guy's perspective, right? It's just, this is a model that I came up with. It makes sense to me. The MPA Ethics Committee, we use this model. I've written about it, I talk about it, but it's just one guy's approach, right? It's helpful, I think, for you to know who this one guy is. As we discussed, I'm in private practice. I do clinical work with adults. I do consultative work. I do a little bit of forensic work. I specialize in disruptive, working with disruptive behavior and talking about ethics. I'm currently on the faculty of Loyola University, Maryland, just completed my 18th year there, and taught at Hopkins for probably about 10 years or so. Um, and then I serve a few different roles with the Maryland Psychological Association. So, I try to spread myself not too thin, but I like to do a lot of different things. This is kind of the roadmap maybe for what we're going to be talking about tonight. Usually, when you follow GPS on your phone or on your car or whatever, it gives you step-by-step instructions, do this, don't do that, turn right here, sort of thing, and it gets you to where you need to be uh, pretty reliably. The problem is that once you're there, if your phone dies, you're not going to know how to get back home, right? Where if you go old school and you learn how to use a compass, if there are young people out there, that's a compass, by the way. Um, if you learn how to use a compass, you learn how to navigate through all different types of situations. So instead of just mindlessly following step-by-step instructions when approaching ethically compromising situations or ethically challenging situations, I should say, I really want you guys to utilize more general guidance, develop skills and sound judgment, so that you can continue to think on your own rather than rely on other tools. Now, I think it's helpful to start with just a very generic model of problem solving, right? So to solve a problem, you have to start by knowing that there is a problem. So we identify that there's a problem. We consider what resources we have to deal with the problem. We then generate a list of potential options. We choose one, and then hopefully we look back and assess how well we did. Did we use the right resources? Did we make the right choice? And then the next time that we're going through that cycle again, we know to approach it either similarly or differently based upon the information learned through this cycle. So again, this is just a very generic way of thinking about problem solving. So, with that, what are some resources that we have to deal with? So, I gave you the little intro about myself. Here are some resources that I can rely on, or that I need to utilize when thinking about what I'm allowed to do, what I'm not allowed to do. So, for me, or for most of us, for all of us actually, if we're licensed, is the Health Insurance Portability and Accountability Act, or HIPAA. An example of a federal law. A state law for me would be the Health Occupations Article, Title 18. I don't know what the physicians is. It's probably closer to like 10 or maybe even lower than that. And then the regulations that are enacted by Title 18 are Department of Health and Mental Hygiene's Title 1036, which is the Maryland Psychologists Act. So those are state laws and regs that I have to follow as a licensed psychologist. And then, I mentioned that I teach at Loyola, so I have to follow the academic regulations and policies of Loyola University of Maryland. Now, if you work at University of Maryland, hospital, you're going to have to follow their policies and procedures. Or if you're at Hopkins, you're going to have to follow theirs. And so it's helpful to know what policies and procedures should be regulating your practice in your setting. Maybe you're in a private practice setting or a small group or something like that. Again, there should probably be some sorts of policies, whether formalized or not. And it's helpful to know what those are and to rely on them as resources. Another resource that we have available to us are our codes of ethics. So for me, it would be the American Psychological Association's Code of Ethics. That's what I tend to talk about the most. But for today's talk, I am going to lean into the AMA's Code of Ethics. So I oftentimes will ask, but in the interest of time, I'm not going to bother. Like, when was the last time that you actually looked at your code of ethics? Usually, the response is that the modal response that I get is years. Usually before the pandemic was the last time I actually pulled out a copy of my code of ethics. Um, I would encourage you to refresh to look at it. It's available online. All the codes, whether you're a social worker, counselor, psychologist, psychiatrist, physician, they're all available online. You don't need the hard copies anymore, though you can get those as well. So let's jump into the AMA's code. So like most codes of ethics, there are several different sections. The preface, the preamble, the principles, and the opinions. Now, I kind of like the this code, even though it's structured a little bit differently than the codes that I'm used to talking about. The preface is kind of a user manual for how to use the code, including a definition of different levels of obligation, where they define what must, should, and may mean, and that helps guide the user in following the code. There's a preamble, which is a brief mission statement, but it actually gets a little specific in focusing on the responsibility that physicians have and the hierarchy of that responsibility, where the top of the hierarchy is that the patient comes first. And that is followed by what's good for society, what's good for other health professionals, and then what's good for the physician themselves, which is a very interesting kind of orientation to how we approach decision making. So, patient first, obviously. And then the two sections that we're going to talk much more about today are the principles and the opinions. Now, the principles are kind of like that compass. And that's what I'm going to really urge you to shift towards rather than the GPS opinions. The opinions, there are 11 chapters, and I'm not quite sure why they call them opinions, but opinions of the Council on Ethical and Judicial Affairs. But there are 11 chapters of what I'm going to call actionable standards, even though standards is really not the right word. I use it because it comes up later in my presentation. Actionable standards or enforceable standards that apply that apply the principles of medical ethics. The principles of medical ethics are 9 core overarching non-enforceable values. They're value statements about compassion and respect, professionalism, respect of the law, confidentiality and privacy, advancing scientific knowledge, freedom of choice, improvement of public health, responsibility to the patient, and support of access to medical care. Right? So there's a lot of social justice here in these principles, in these values, right? Which again are not directly enforceable, but the opinions are enforceable, and they rely upon these principles. I hope that makes sense. So we can almost think about the principles being a foundation for these actionable opinions. And again, like the metaphor that I have with the compass and the GPS, is that for a GPS to work, it really has to be based on your bearings, knowing which way is north. Now the phones do that for us nowadays, but it's helpful to have that sort of orientation. So I hope that that's clear. I hope that this isn't new information. Because all of us had to study our own codes of ethics. The other codes of ethics for psychologists, for social workers, are very similar, with some deviations, but very similar and definitely applicable as we continue with this. Now, I like to think about moral reasoning, right? And the different levels of moral reasoning, right? With pre-conventional, the most rudimentary level of moral reasoning being pre-conventional moral reasoning, where we avoid punishment for my own sake. right? I don't want to get in trouble. I don't want to get reported to the board, so I'm going to follow the rules. A higher level of moral reasoning is when I follow rules because there are rules. I follow rules for the sake of rules. And so that's kind of following those standards, right? There are rules. Somebody smarter than me put these rules in place. I guess I got to follow them, so I will. And that's following those ethical standards or the opinions of the AMA code. And then a higher level, is post-conventional moral reasoning, and that's doing the right thing because it's the right thing, doing it for society's sake. So again, it's kind of following a higher standard, and it's being guided by those ethical principles, those aspirational principles. So again, I'm kind of explaining to you that I'm really focusing on giving you that compass to follow those aspirational principles today, while knowing what the standards are as references or resources. Just an interesting quote from the first version of the Ethical Standards of Psychologists, dating back to 1953, emphasis added by me. Psychologists are aware that a good code of ethics must be more than a description of the current state of ethics in the profession. A code must embody the ethical aspirations of psychologists and encourage changes in behavior, bringing performance ever closer to aspiration. And that really kind of speaks to this point that I keep bringing up of the compass versus the GPS. Um, as Margaret explained, I'm on the ethics committee for MPA, and the lawyer who was on our committee for years and years, for much longer than I was on it. I've been on the committee since the early 2000s. So he and I used to. I love the guy, Richard. He and I used to argue a lot, and I love getting into arguments with him because he's so smart. And this is actually a model of a hierarchical model that he would talk about all the time, that law trumps regulations, which is true, right? And that laws and regulations trump ethical codes, which trump morals, personal morals. And I have this labeled as an artificial hierarchy because I don't agree. I don't think that this is true. I don't think it's that linear or that direct where the law is always followed. And the kind of classic example that I give is on my drive home today, as long as it's not raining too bad, I'm probably not going to be driving 55 miles an hour on 695, on the Beltway. I'm probably going to break the law. Don't tell anyone. But I'm probably going to break the law and go beyond the speed limit of 55 miles an hour. Now, I know that if I get caught going 60, 65, that I could face some problems. I could get a ticket, right? My insurance could go up. But I make a decision that I'm going to break the law in this case because I think the risk is worth the reward. And the fact that matters is that we all do this in practice as well, um, in some way or another. Um, and that's dangerous, right? It's risky. And so we need to think about this, but be honest with ourselves about when we don't necessarily follow Richard's hierarchy here. And so instead, I came up with this model, which started off with just those colorful circles and not the gray encompassing one. Um, and I call it clear lenses, right? And clear standing for clinical, legal, ethical, administrative, and risk management. I wrote this up and I presented it to my ethics committee, and people really embraced it. And as I said, we use this when we handle phone calls from members of MPA. And then we decided to kind of broaden it. And the plus lens, so now it's called clear plus lenses. The plus lens is all encompassing. Now, first, and I'll explain that in just a moment, but first you'll see that the way that I have the diagram set up, the clinical lens overlaps with the legal lens, it overlaps with the ethical lens, with the administrative lens, and the risk management lens. It also overlaps with the legal and the ethical, or it overlaps with risk management and administrative, right? And so all those little color permeations are examples of how one lens overlaps with others, maybe just one or two or all five, right? All the rest of the lenses. Um, and I think that's an important thing to think about because as we're going to go into more detail about this, we're going to see that we're going to talk about something that fits in a clinical lens, and then it's going to come up in ethical or maybe in legal, and then also in risk management, right? And that's very deliberate by design. That what I want you guys to do is and I'll present a case in a moment. When I present a case, I want you to, or thinking about your own cases, I want you to look at the case imagining that you're picking up a clinical lens and looking at it. And then you're putting that down and picking up a legal lens and looking through that lens at your situation, putting it down, looking at it through an ethical lens, an administrative lens, a risk management lens, and then this all-encompassing plus lens is really kind of a systemic lens that's looking at things like diversity, inclusivity, bias, similarities, differences, systemic factors that affect the practice of medicine, right? So that societal stuff that we saw when we were looking at the principles, right? So here's my model. That's the money shot, right? This is what this is all about. So let's just jump into a case. It's a fictitious case, but most of my cases are based somewhat in reality. Some of the quotes are directly from patients of mine who have been referred from the physician health program or physician rehab program. And by the way, I should say that the image that I used was generated by Gemini, and I just noticed today that the resident has two ID badges, and his on his left hand, his fingers go too far, too deep, and apparently the patient has her gown tucked into her pants for some reason. So far from perfect, but I just wanted full disclosure and letting you guys know that was AI generated. So the title of this is Disruptive Resident. And so I'll just read it to you. A third-year resident picks up additional clinic patients while expressing frustration, stress, and burnout related to working with these lazy and incompetent colleagues of his. He grows irritated because a 17-year-old Karen patient, Karen in quotes, asks him way too many stupid questions. The resident rolls his eyes and utters something about a personality disorder to the patient's boyfriend while he's leaving the exam room. The patient gets angry and threatens to leave against medical advice. The next day, the resident gets called into his residency director's office because an anonymous complaint was received. So again, this isn't a real case, but it is based on multiple cases that I've seen over the years of doing this type of work. So think about this for a second. So what are some of the issues, right? If we were having an interactive discussion today, we just don't have time for that. But if we were, I'd ask you guys, so what pops out at you? Like what really jumps out of this case? It's probably going to be how rude the guy was. I mean, after all, the title is disruptive, right? The comments that he's making, lazy and incompetent, right? So let's start to look at this case through each of these lenses. So let's first hold up the clinical lens. What I'm going to do is each of these slides, each of the next few slides are going to be one slide each for each lens. And when we're going through, the larger font is just a handful of examples of things that we might consider when looking through a clinical lens or looking through a legal lens. These are not exhaustive lists, not even close to exhaustive lists. They're just a handful of examples for each lens. And then some of them I left in there that might not be applicable in this situation. Like, for example, theoretical orientation and technical skill, right? Like, I don't really think that theoretical orientation in medicine really applies to this case and holds much weight in our reasoning through, what's gone wrong and what can be done differently in this situation. But competency, expertise, experience, those are clinical issues that surely are relevant here, right? The resident was seeing way more patients than the than his colleagues. Was he seeing too many patients? Is he going too fast? Is he showing off rather than providing good care? The diagnosis, right? Diagnosis can oftentimes mediate, how things are going to play out. So, for example, if the patient had, in fact, a personality disorder, that might lead to a different outcome than if the patient does not have a personality disorder. We could also argue that if the resident has a personality disorder, that could affect the outcome as well. And so that's something to consider as, in addition. A lot of the examples are going to be that I have here, like transference and countertransference. So that's a psychological construct, right? So transference is when the patient distorts reality, sees me in a different light, might transfer onto me, project onto me feelings that she has about her dad, let's say, right? Countertransference is when I distort reality and I project onto her, feelings. I might fall in love with her or I might hate her, right? So those are, a very Psych 101 example, a description of transference and countertransference. But, as it applies here is the resident's bedside manner, which was quite lacking, empathy, which was quite lacking, right? And then termination. So how I terminate therapy, or in this situation, whether this is in an emergency room or just making rounds or whatever, the patient is threatening termination of care, threatening an AMA discharge, and that the discharge could be dangerous depending on what her diagnosis is. And I'm not talking about psychiatric diagnosis now, I'm talking about why she's in the hospital or in the medical clinic or wherever she is, right? So that's just an example of looking at our little scenario here through a clinical lens. And there, I'm sure, are plenty of other things that we could throw in as well. Let's move on to the legal lens. And again, just a few examples. So just the Health Occupations article of Maryland 1-225 requires all licensed healthcare practitioners to complete training on implicit bias and structural racism. By the way, the structural racism component was just added on April 1st of this year. So there is, next time that you're renewing your license, there will be an extra course that you need to take, just as a little FYI. But the reason why I included that, other than to give you that little tidbit of knowledge, is that we need to be sensitive to our own implicit biases, and to the implicit biases of others, including our patients. How she might be reacting to him in this situation, as well as how he might be reacting to her, calling her a Karen, right? I mean, that's awfully rude. HIPAA, right? So as he was walking out the door, the resident muttered something to the boyfriend, I guess just to vent or to grumble or whatever, maybe thinking that he would get like a, yeah, I'm with you, man, from the boyfriend, which of course I'd imagine he wouldn't. It was breaching confidentiality. It was talking about a patient in front of somebody else presumably, without the patient's express consent, right? Hospital policies. So the hospital has policies about how to handle AMA discharge. The state has laws about how to handle AMA discharges. The hospital also has policies about conduct and about employee conduct. And that, the guy got called into his residency director's office the next day for a reason. And he's going to have to kind of, face the music there. Health General Article 20-102 references treatment of minors. Remember, this Karen patient, so to speak, is 17 years old. Now, 17-year-olds are under 18. I did the math in my head just now. And but they can consent to treatment, and they can consent to to terminate treatment. There are exceptions to that, but that is that some minors are able to consent for treatment. You don't have to be 18 to seek treatment and to terminate it. Could go into more detail about that, but it's not necessary for the sake of today's talk. Um, the resident has to ensure that the patient understands the risks of refusing treatment, and that as a minor, that responsibility is elevated. So that's another thing that he needs to keep in mind from a legal perspective. So here's again just a handful of examples of some legal resources that our resident should be considering instead of, trash talking the patient and doing so in front of the patient, in front of the boyfriend as he's walking out the room. All right, let's jump into ethical. Now, I told you I've got one slide for each lens. That's not entirely true. I have two slides for ethical, one for the principles and one for the opinions or the standards. So the principles of medical ethics. And again, that's the general guidance, the aspirational guidance. I listed the nine principles, but so compassion and respect. The resident was blatantly disrespectful, was rude, right? Professionalism. He was behaving in what we could call a disruptive manner. By the way, that's a whole nother talk, is just talking about disruptive physician behavior. Confidentiality, so confidences and privacy. There was that I don't know, I was going to say inadvertent disclosure to the boyfriend. Was it inadvertent? I don't know. Was he just venting? Either way, he was talking about a patient in front of somebody else who does not have consent, who we're presuming does not, he does not have consent to do that for. And then responsibility to the patient. He must make sure, as I said, in the legal lens, he has to ensure that the patient understands the risks of discharging, of leaving against medical advice. So there's just a couple examples of overlaps between legal and ethical, right? Same thing's going to apply here in a moment. We have to agree. We have an agreement in principle. The question is, do we all have the same principles? And here, hopefully we do. So here's the other slide, the standards or the actionable opinions of the AMA code. And so these are the, I think, 11 chapters of opinions, which I think total up close to 200 actual opinions, something close to 200, I think 190 something. The chapter of patient-physician relationships, there is a very inappropriate interaction, not to the patient, between the patient and the doctor, right? Again, the disclosure to the boyfriend is an example of privacy, confidentiality, and medical records that was violated. Professional self-regulation, there's a chapter of opinions about that. And, the overall dysregulation of the physician and how out of control he really was by speaking this way about his patient, to his patient, in front of his patient, potentially an earshot of the patient afterwards, all that kind of stuff. And talking about interprofessional relationships, all my stupid, lazy, colleagues. Venting about the colleagues is a good example of not following, the opinions related to interprofessional relationships, right? And again, there's plenty more here. These are just a few examples. So, by the way, when I first came up with this model, I had CLER, and so I just had a lowercase a. And then a bunch of things started coming up as we were handling calls that were like about practice management, about business records, about things like that. And I figured, well, that's got to fit somewhere. And sometimes it was legal, sometimes it was risk management. But then I thought, what's a good A word? And so I came up with administrative lens, right? And so the administrative lens can cover things like record keeping, fees, use of insurance, billing practices, things like that. Um, Here in this case, um, the business contracts, right? So there is essentially a business contract between the resident and the hospital, right? That's an employment contract. There's also regulations that need to be followed, which could go under the legal lens as well, between the ACGME and the hospital and the resident, right? And so the resident's got to follow ACGME guidelines and policies. Um, if he gets suspended, let's say, for a period of time, that's going to affect his PGY3. Um, and he might have to spend extra time to make up for those missed days or weeks or whatever. Um, Policies, protocols, precedents, how the AMA discharges are handled. So those are just general policies of a hospital. How complaints are handled. Remember, there was a complaint that went to the residency director, and then internally within the residency program of this resident's specialty, how the residency director then handles that internally. Presumably, the residency director speaks to the chair, then speaks to maybe a couple faculty members, and then to the resident for potentially for disciplinary action, which would be another thing to add to administrative and to legal. And then supervision, right? So is there disciplinary action that's going to follow the complaint? And then let's talk a little bit about risk management. So with risk management, I like to think about informed consent, documentation, and consultation. That those are kind of the three clusters of things that I'm thinking about when I think about risk management. And so I've got the ICDC using the ACDC font, and I like that, and it makes me smile. So I'm using it with you guys as well. So informed consent. So in this case, we've got a minor patient. And as I said before, the minor patient can consent. It's still, when possible, it's still a good idea to get a parent or a guardian to consent. We're not sure if that happened. So that's just one example of informed consent issues. Documentation. Documentation that this is a challenging patient, how one does that in a useful and not pejorative way that won't hurt her in the future or won't hurt the documenter, the physician who is doing the documentation, because after all, she does have access to those records. And documentation of the AMA discharge, of course, is going to be necessary if that comes to fruition. And then consultation. So hopefully the resident is in close consultation with his attendings, and is talking about the situation, hopefully in a very timely manner so that the attending can go in, apologize on behalf of the resident, maybe coach the resident on how to apologize on his own behalf or whatever, right? So these are the first five lenses. Before we get into the plus lens, I do like to lean a little bit more into risk management. I promised you in the beginning that hopefully it's not going to be boring. I can't promise you that it's not going to be boring. I don't think it's boring, but I did promise you that it's not going to be scary. But I do want to lean into this a little bit more. So let's talk a little bit about informed consent, documentation, and consultation. So informed consent is not, it's not just a piece of paper, it's a process, right? Patients don't read that piece of paper that they sign or the electronic thing, they just scroll and then, initial or click yes or whatever, right? I don't read it, you don't read it, your patients don't read it, right? So it is a process, meaning that we need to talk with our patients. Now, in my practice, it might be even more relevant because I'm doing psychotherapy, right? It's more intimate. Confidentiality is different. I mean, it's same laws, same rules, same policies, right? But it's oftentimes of a higher sensitivity than someone who's treating someone with COVID or the flu or a broken bone, right? But it's more than just a piece of paper. I'll also argue that it's more than just that process. It really is a concept. It's an aspirational concept founded on beneficence and non-malfeasance, right? So beneficence, we want there to be ongoing communications between doctor and patient to inform and to increase or improve adherence to treatment. And non-malfeasance, we don't want there to be a time where the patient believed that something was going to happen and now something else is happening instead. So we want to limit misunderstandings by talking about things up front. Um, I'll tell you, I went another question that I oftentimes ask when I'm polling audiences is like, what's your informed consent process like? A lot of people just go off the piece of paper that the administrative person up front had signed, right? And that I think is really scary. So if you're going to get scared, be scared by that practice, right? I really want you guys to be thinking about how you can make this not just the bare minimum. They signed a piece of paper that they didn't read, or they electronically signed something that they didn't read. Making it into a process, but founded on these concepts of not wanting to harm and wanting to do good. So that disclaimer that I flashed on the screen for about 5 seconds in the very beginning, this is the verbatim. I just accentuated a couple lines. One line says that all parties present agree to write in the chat feature at least one glowing compliment about Michael Heitt during this presentation. And at the end, it says, by remaining awake during the display of this slide, you're hereby indicating your complete understanding and acceptance to all of the above policies and disclaimers. Right? So I'm going to expect really, really good reviews from you guys. Right. So it just goes to show that, people don't read it. People don't even, the person who's presenting the disclaimer or the informed consent documentation oftentimes just throws a piece of paper at them, or, I have to go over before we have surgery. These are the things that could happen. It's not going to happen, but you just sign at the bottom. Right. So you really need to embrace informed consent as a risk management tool. It protects you. What should we inform people about? We should inform them about limits of confidentiality, about risks and benefits of whatever it is that we're doing, whatever service we're providing. We should tell them what services we are providing. Like, so, for me, I had the what's the plan slide. And I told you we're gonna introduction and contextualization. We're gonna go over models of problem solving, some resources, and then we're gonna talk about this model of the Clear Plus lenses, right? So that was another example of informed consent, right? So you guys got informed consent by me. You got consented by me. Um, uh, uh, the competencies and the limitations. Remember the one guy's approach? I told you, listen, I work with adults, I work with this, I do that. I don't work with adolescents. I don't work with children, right? That's a limitation. If we were, presenting other cases about children, I'm probably not the best guy to talk to, right? So that's a limitation of mine. It's a limited competency of mine. And it's important for my patients to know that. And it's important for your patients to know what you are going to do and what you're not going to do and why you're not going to do the things you're not going to do. Um, um, we want our patients to be informed about their access to records, about billing. There shouldn't be any surprises. There's that no surprises thing, that law that was passed a couple years ago. What happens in the case of emergencies? And again, this is not an exhaustive list of informed consent, but it's just a bunch of examples of things that you might want to think about when thinking about informed consent. D, documentation. Um, so why do we document? We document for a lot of reasons. We document to track progress. We document to remind ourselves. Before I see a patient, I pull out their chart and I read the last couple notes to catch me up to speed. Oh yeah, that's right. I know where we left off. I know kind of what was going on and where my patient is and what I should expect as they walk into my office. We document to demonstrate your actions and your thoughts, to demonstrate a reasonable standard of care, which is a technical term. That is what you will be held up against if you have a complaint to the board. Is did you follow a reasonable standard of care, or what a reasonable peer would do in that situation? The good old mantra, if it isn't written down, it didn't happen. Not only should you write down or should you type what you did do, you should document what you didn't do and why. Right. So in my situation, I have patients who are suicidal sometimes, and sometimes, most of the time, I do not hospitalize them because they don't need it. But I do document that we talked about hospitalization as an option and why we're not hospitalizing the person. Because if I didn't document that, and something bad happened, it would be, the opposing attorney at my lawsuit would say, so Dr. Height, why didn't you hospitalize the person? Oh, well, we talked about it, but I don't see anywhere in the notes that you talked about it, right? I don't want to be in that situation. We document to for justification to third parties, to payers, to supervisors. We document to communicate with others. So it's it's really important to anticipate who your reading audiences might be. The reading audience might be a supervisor, it might be a peer, it might be a specialist that you refer to, it might be the patient, it might be somebody else. Your documentation has to be legible, organized, safely stored, and accessible. So you don't want something like this to happen. Oops, I just deleted all your files. Can you repeat everything you've ever told me? And I'll pause for laughter now. Um, this is one of my favorite articles by Guthiel, 1980. It's an old article, but the title of the article gives it away. Paranoia and Progress Notes, a guide to forensically informed psychiatric record keeping. And there's this little call-out box that I like to quote. In writing progress notes, my trainees are urged to hallucinate on their shoulder the image of a hostile prosecuting attorney who might preside at the trial in which their records are subpoenaed. Again, I don't mean to scare you, but I do want you to remember this quote when you go to work tomorrow and you're typing up your notes. Anticipate your reading audience, including that hostile prosecuting attorney who might preside at the trial in which your records are subpoenaed. Write your notes for her, for him. C, ICDC, consultation. We consult to enhance our competence, to enhance our knowledge base. We might consult to kind of wrap our heads around a situation intellectually and emotionally, to kind of get an emotional check with somebody, and to gain perspective. We also consult and then document our consultation, by the way, to demonstrate a reasonable standard, that it's not just me winging it and making decisions on the fly. Is I actually consulted to Dr. Burns and Dr. Smith, and and they said that they would probably do the same thing. And so there you go. So that's documenting a reasonable standard. And then we also consult when we're collaborating with other parties. So when we're referring to specialists, as an example, or when we're sharing our notes with or reaching out to primary care providers. So that's ICDC, which is kind of the crux of risk management. Lastly, I believe this is lastly about these slides, and then we'll get onto the plus lens, is defining goals, right? It's important to define goals and define roles, differentiating consultation from supervision. Supervision is hierarchical. It's when you were a resident and you were functioning under the resident above you, which is functioning under the attending, right? And so when you're practicing under somebody else's license, you're in supervision. With consultation is among peers. Though we can use a broader definition of consulting as well, and saying that when you're seeking information, you're consulting. Um, the quality of the data that you share with your consultant, with your peer, will determine the quality of the outcome of the consultation. So good data in, good data out, junk in, junk out. And it's important to be open to that feedback. And then that overarching lens that everything falls in the context of is that plus lens, right? This is where we're trying to, avoid blind spots. That's why I've got that little graphic of the mirror on the side of the truck, right? So we need to be sensitive to context, to different worldviews, to blind spots. So appreciating in that situation with the 17-year-old patient and the PGY3 resident, anticipating that the patient might have been really anxious, right? She's 17, maybe she's at the hospital by herself. There's no parent with her. This might be her first time in the hospital. That's why she's acting in whatever way she's acting. So being sensitive to that, being aware of systemic and structural issues, right? Differences in experience, differences in training among colleagues would be examples of systemic or structural differences. Cultural issues, identity issues, diversity issues. So applying that Karen label is very pejorative, right? The image that I had, I think that the patient was Asian and the resident was black, right? And so there are potential ethnic and racial issues present in that case. What they are, we don't know. It didn't necessarily follow, but who knows, right? Demographic variables, right? So we mentioned that the patient was 17, so she's a minor. Power and privilege differentials, and this is one that is so often overlooked. The power that the provider, that the physician has, or the whoever the provider is at whatever level that you have over your patients, you may not care much about that. I'm telling you, your patients do, right? And so humility, awareness are, of this is really, really important to avoid bias, to avoid oppression, inadvertent oppression, right? And so that's that overarching lens through that everything has to be looked through, right? So we went through this very complex model pretty quickly. And oftentimes this talk that I give is actually a 3-hour talk rather than a 1-hour talk. But we went through this pretty quickly, talking about the overlapping structure of this, how it's integrative, it's deliberately integrative, and it gives you the opportunity to pause in a situation and think logically and coherently. Let me look through this lens, let me look through that lens, and let me take this very structurally so that I'm making a decision based on good data, right? We talked about the clear lenses. By the way, if you want to read a little bit more about it, here's a shortcut URL to it, rebrand.ly/clear-lenses. I don't think you need to capitalize it. I'm not sure. We talked about ICDC, just a good acronym to remember: informed consent, documentation, and consultation, as that risk management lens, because we focused more time on that because that's what we tend to focus on, right? And then we really reviewed a lot of the medical ethics. I'm sorry, the code of ethics. I've got some references that are in the slides. And that's a very good question, which is why we're going to move on to the next question. So let's jump into to whatever questions might have been submitted, or any questions that you guys have.
Okay, thank you so much, Michael. That was a lot of information. That was great. I don't see any questions in the chat, which I think is probably because I'm seeing excellent talk. I think you were chock full of really good and very interesting information. So I would really encourage folks, if you have a question, comment, please unmute yourself, ask the question, or if you want, by all means, type into the chat. But excellent talk. Thank you.
Thank you.
Excellent presentation. I
Yeah.
agree.
And again, there's a lot, I threw a lot of information at you guys, and it's a lot to digest. Um, and that's why I use those the acronyms, the clear lenses. You can think, wait a second, what do they stand for? I know the C is clinical, L's legal, E's ethical. Those are easy ones, right? But that A one, oh, that's right. That's the one that he couldn't figure out what to call it. That's administrative. And then R, whenever we're talking about these types of situations, risk management. The plus lens is a little bit harder by the way, the reason why it's a plus lens rather than something else, rather than like S, is because like clears lenses didn't sound good. So we just added it on as a plus. And it also kind of paying homage to like the plus at the end of LGBTQ plus, right? Is that it's saying that there's a lot more here. And even just saying something like LGBT leaves out a lot of people, right? And so adding on a plus is helpful. And so that plus lens is that overarching thing that we're lens that we're looking through. Um, and don't forget you can in the slides is a link to my website. If you have any questions, you can contact me, and the URL for that little article that I wrote about it.
That is great. Again, great information. Do have a question. What can physicians or other healthcare professionals do to help patients with implicit bias?
That's a good question. That's interesting, right? So think about what your role is. If the patient's implicit biases are getting in the way of medical care, or affecting their health in some way, then patient education makes sense. Um, uh, but in general, our role is not to educate patients about cultural issues necessarily. So I think that that's a decision that you need to make based upon the individual situation that you're in with that individual patient on that day. That's a toughie though. It's a tough question or a tough situation.
Absolutely. All right. Thank you to that. Given there is increasingly less time for patient care, what are best practices for consent that won't eat into patient care time? Nurse's role, video. Thanks for a great talk.
Oh, good. So, great problem, right? I mean, I'm not working at your clinic, so I'd say spend a few extra minutes. That doesn't help you though, right? I think that there are shorthand ways of getting across the bare minimum, right? So for me, I've got a several page informed consent document that people don't read but the initial testing that they did. And then at the start of the first session, the intake session that I have with patients, I say, I refer to that. I say, thank you for filling out your intake paperwork. At the bottom of it said that you read and you understood all the fine print below. I know many people don't read the fine print. I actually encourage you to go back and do it. I know that most of my patients don't go back and do it, by the way. And then I say, but before we get started, there are a few things that I want to go over. Nothing that you don't know already, but I like to talk about it with everyone. And then I give them, takes about I say, confidentiality, the things we talk about are confidential. Friends, family, coworkers, others don't have access to this information. Limits confidentiality so if you're danger to yourself, danger to others. If there's a dependent adult abuse or child abuse, that's reportable by law. Pretty much other than that, I need your permission to talk about anything with anyone, right? That is not comprehensive at all, but it gets really kind of for psychotherapy, the most important thing out on the table. And then sometimes people will have questions, in which case I'll go into more detail. I know I have the luxury of time. I've got 45 minutes with my patients. You've got 8 or 15 if you're lucky. Um, so maybe talk with colleagues. So, consultation, talk with your colleagues in your practice setting and find out what they do, or, maybe come up with some ideas of what you guys can do on a regular basis.
I do like the one thing in this question of video, and wonder if sometimes we could use technology a little bit more um, in a more targeted way to do these things. Since definitely people seem to be a little bit more engaged by something that they can kind of see, maybe on their phone, someplace like that. So
Yeah.
don't know if anybody's, kind of explored that and wonder how it works.
Well, I'll give you an example of, I actually did that once. During the pandemic, I came into my office every day. Nobody else did in the entire building. It was very lonely. Um, but, so I stood here, seeing my patients online. When people started coming in, once the shutdown was, and things were safer, I had a whole list of rules, in our office. You got to wear a mask. I'm going to wear a mask, blah, 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 blah. There's sanitizer over there, all that kind of stuff. And again, I knew people weren't going to read it. And so I'd send that out to people. And then I'd say, please click this link for I think it was like a 60-second or maybe a 30-second video. And I don't know if anyone's ever heard of this website. It's called Fiverr, Fiverr.com. I think it cost me $5, or it might have cost me $10. I don't know, to have someone create like a whatever, like a 30-second video for me of somebody calling from their car saying, "I'm here, can I come in?" rather than sitting in the waiting room. And then don't forget to put on your mask, and don't forget, and all the rules were in that little 30-second video. It's still on my website somewhere. It probably is like pikesvillepsychologist.com/COVID is my guess. Or if you write to me, I'll find it and I'll send it to you. But again, it was like $5 or $10 to have it done.
Ah, interesting. Great,
Yeah,
great. Other questions? Again, feel free to unmute and ask the question if you would like to do it that way.
don't be shy.
Yeah, don't be shy. One thing that you do mention that I find sometimes can be kind of problematic for folks, not just in behavioral health services, but in any kind of medical service, is that countertransference, and
Mhm.
how sometimes that can really pose a lot of challenges if we don't really pay attention to it. I wonder if you could speak maybe a little bit more about that.
Right. And so again, as a reminder, the transference, countertransference, it's these reactions that we have to patients, right? And so, oftentimes in psychotherapy, we talk about eroticized transference, where the patient might feel romantic attraction, or where the provider might feel a romantic attraction toward the patient. And I've dealt with those types of situations and referrals that I've gotten from the PHP and the PRP at MedChi, of folks who have gotten themselves in situations where they thought that they were really in love with the person, and that the person was able to consent to an adult consenting sexual relationship, not taking into consideration the hierarchical situations. It's really important to keep your own thoughts and feelings in check and to be aware of them. So, as an example of that, in psychology, in graduate school for psychology, I encourage all of my students, just like I was encouraged, and my peers were encouraged when I was a grad student a million years ago, to be in therapy for a period of time, right? To just get a good check on what are my issues, what are not my issues, so that then when a patient's acting in a certain way, I know if they're playing off of me, if my reaction is about me, is about them, or whatever. So ultimately, it comes down to self-awareness, which unfortunately a lot of people are kind of lacking in. Particularly about being able to recognize their feelings and being able to distinguish my feelings that I have outside of work versus the feelings that I have at work.
Absolutely. Thank you.
Yeah, yeah.
Okay. Any other questions? Well, thank you so much. If there are other questions, please, by all means, shoot me an email if you know kind of are thinking about all of this and something pops in to your head. Let me know, and I'll be happy to pass it along to Dr. Height. But right now, I want to um, have all of you join me in thanking Dr. Height for being here. I want to thank all of you as well for being here. This was a wonderful, very interesting presentation. I think a great way to look at ethics. So I'm sending a ton of gratitude out to everybody. Thank you so much for your support of the Lemons to Lemonade series. I think you may have seen in the waiting room that our next lecture will be on June the 30th with Sally Moody of Forest Health Pine Grove, and she'll be talking about professional boundaries. So another thing that I think connects with the presentation that you did tonight. So really happy to have you and then be followed by Sally.
Yeah.
So please continue to support us by tuning in next month. Consider a donation to the center. Know that your donations not only keep this series going, but also help us fund the important work that MPHP does. So again, much gratitude. Um, Michael, thank you so much for this. Thanks to everybody for being in attendance. I want to wish everybody also a very wonderful holiday weekend. I don't know if around where you all are, but it stopped raining here in the city. So, yes, we should be able to go home safely without the rain pelting us. So, again, thank you all very much and have a great rest of your evening.
Thanks, everybody.
Thanks.